Hello and welcome to this module on Epidemiology Essentials. My name is Dr. Namdi Moiteke with the Department of Community and Public Health at Idaho State University. We'll begin with the first unit of this module, which is History and Field of Epidemiology. The World Health Organization defines epidemiology as the study of the distribution and determinants of health-related states and events, including disease, and the application of this study to the control of diseases and other health problems. According to the United States Centers for Disease Control and Prevention, it is a study which is scientific, systematic, and data-driven of distribution and determinants of health-related states and events, not just diseases, in specified populations. Epidemiology is a study of the distribution of health outcomes or diseases within populations and the factors that determine the spread of health outcomes and diseases. These factors that determine whether someone gets a certain health outcome or disease are called risk factors. Epidemiologists focus their attention at the population level rather than the individual level. In order to understand epidemiology, it is first helpful to review some of the basic history of the field. People have long viewed epidemics of disease and plagues as terrifying occurrences. There has been a continued desire to have a more rational and complete way to explain diseases and, more recently, other health outcomes, rather than believing that diseases were simply caused by spirits or a god. Empirical observations of epidemics and other causes of mortality were the beginning of the field of epidemiology. Epidemiology's focus was initially on infectious diseases until early in the 20th century. By the mid-1950s, epidemiology's focus then included not just infectious diseases, but specific conditions associated with them. In the 1960s, epidemiology began to focus on laws regarding the distribution of disease at a community level. Then, in the late 1980s, epidemiology focused on how to control or minimize health problems and diseases. Towards the end of the 20th century, computers, increasing information technology, and the new methodological approaches altered the field of epidemiology, and it has become a standard area of clinical science and is the most fundamental basic science of public health. We begin with pioneers of epidemiology, and the first person we'll be looking at is Hippocrates. Hippocrates was a Greek physician considered by some to be the first epidemiologist. He wrote a book called On Airs, Waters, Places, where he described epidemics. He thought about environmental and behavioral issues that might be associated with disease. Hippocrates focused on rational explanations for disease rather than supernatural explanations, which were the norm during his time. For example, Hippocrates described the malaria parasite periodicity and the malaria paroxysm. He was in favor of swamp drainage to prevent miasma or bad air, as he observed its link with yellow fever and malaria in people living near these swamps. Girolamo Fracastoro was an Italian physician who showed several ways that transmission of infections can occur by direct contact, by air, and via contaminated clothing. In 1546, Fracastoro presented his writing on contagion and contagious diseases and proposed that diseases were each caused by a rapidly multiplying seed. He proposed that the seeds were transmitted by direct contact, air, or contaminated garments. John Gaunt calculated survivorship on a chart, and he presented population and mortality statistics in London during the time of the plague. He did an analysis of the vital statistics of people living in London and published it in his book Natural and Political Observations Made Upon the Bills of Mortality in 1662. This publication was the first estimation of the London population that was statistically based. The statistical and census methods that he developed and used became the basis for modern demography. James Lind was a Scottish physician who was interested in the cause and treatment of scurvy. In the 1700s, during circumnavigation of the world by ships, many sailors died, and many of those who died supposedly from scurvy. Lane theorized that citrus fruits could cure scurvy. Scurvy is now known to be caused by deficiency of vitamin C, a micronutrient contained in citrus fruits. But back in the time of Lind, vitamins were unknown. Lind had the idea that something was lacking in the diet of the ill sailors, and he chose 12 men from a ship, all with scurvy, and sorted them into 6 pairs. All of the sailors received the same basic diet, but he gave each pair a different supplement. Group 1 received a quart of cedar daily. Group 2 received 25 drops of sulfuric acid. Group 3 received 6 spoonfuls of vinegar. Group 4 received half a pint of seawater. Group 5 received 2 oranges and 1 lemon. And the last group received a spicy paste. Group 5 could no longer be treated after 6 days when they no longer had any fruit. However, one sailor in this group was already able to walk, while the other sailor had almost progressed to the point that he too could soon return to his post. Lane's work was of benefit to the field of preventive medicine and led to improved nutrition and was the beginning step leading to modern-day clinical trials. Percival Potts lived from 1714 to 1788. He was an English surgeon considered to be the first person to show that an environmental factor could cause cancer. Potts noticed that London men working as chimney sweeps had more scrotal skin sores than would be expected. He noticed coal soot in the sores of the men he examined and concluded that there was an association between men routinely exposed to soot and scrotal cancer. Potts' work was the beginning of modern non-infectious disease epidemiology. William Farr, an English physician considered one of the founders of modern epidemiology, he took statistical data and tested social hypotheses. He also classified causes of death in a way that accounted for broader factors that determine health. He had demonstrated a relationship between population density and mortality rates. Farr also mapped deaths, monitored outbreaks, and developed a new categorization system for causes of death. The mortality data system that Farr developed was an antecedent to the international classification of disease system that we use today. Sir Edwin Chadwick studied sanitation issues in the United Kingdom. He supported the idea that disease was directly related to people's living conditions and that there was a strong need for public health and social reform simultaneously. He proposed improvements such as fresh, clean water, water closets in each home, and a sewage carrying system. John Snow was a London physician, known as the father of modern epidemiology. He conducted the first outbreak investigation in London in 1854. Snow counted and mapped cases of cholera according to where people lived and worked. He compared cholera in different parts of London and came to the conclusion that people who used the Broad Street water pump had much higher rates of illness when compared to people from other areas of London. Removing the pump handle was a control measure that further confirmed John Snow's hypothesis as the number of new cholera cases began to drop. Snow's research showed that contaminated water had spread cholera. Snow is likely the first person who geographically counted and mapped cases of the disease. His work is often considered the beginning of modern epidemiology, the study of health outcomes in populations. As you can see, epidemiology is an integral part of every branch of public health, so it truly earns its name as the basic science of public health. Epidemiology is used to develop, target, and evaluate prevention strategies. Epidemiology is also used to evaluate interventions in the population. Public health interventions can occur at 2 levels, individual or structural. Now we'll look at the perspective of person, place, time in the discussion of epidemiology. Descriptive epidemiology refers to characteristics of persons such as age, sex, race, and socioeconomic status, characteristics of place such as country, province, state, city, zip code, and characteristics of time such as long-term trends, short-term variations by week or day. When we ask what is the distribution or pattern of a disease or health outcome in a population, we are talking about descriptive epidemiology. Descriptive epidemiology deals with the frequency and the distribution of disease or risk factors in populations. Descriptive epidemiology can be used for hypothesis generation, but is usually cannot be used to test hypotheses. Here we see an example of a distribution of disease by person. We have a bar chart which has representation of data for people grouped according to their ages. So the first one for children, the second bar for adolescents, and the third bar for youths aged 5 to 19. Next, we have an example of a distribution of disease by place, in this instance, country. And this pictorial representation shows us the estimated incidence of tuberculosis per 100,000 population in the year 2008. And that is an example of distribution of disease by time. And we see the change in percentage and number of tuberculosis deaths among people living with HIV from the year 2010 to 2019. This also is another example of a distribution by time. The TB incidence in England from the year 2000 to the year 2021. Descriptive epidemiology can be used to evaluate trends in disease, health, and risk factors such as smoking, or determine if a health status is improving or getting worse. It can be used also to determine if new diseases are occurring and provide a factual basis for evaluating public health programs and services. It's also useful in determining if existing programs are effective or if new programs should be developed. And it can be useful in identifying problems to be studied by analytic epidemiology. Analytic epidemiology aims to research and study risk factors and preventive factors for disease. When we ask the question, what are the underlying causes of this pattern of disease or health outcome, and investigate the causes, we are then using analytic epidemiology. Use of a comparison group is a key feature of analytic epidemiology. It focuses on the search for causes and effects on the why and how of a health outcome. For example, a study on the causes of obesity would examine dietary differences among two or more comparison groups. How can researchers determine which specific factors affect the health of a population? One way is to examine things from a population perspective. With the population perspective, we look at both proximal and distal factors. Proximal factors or downstream health factors are micro-level factors that include physiological and biological factors such as genetic makeup, age, ethnicity, gender, and immune status. Downstream determinants typically are related to illness and disease. Risk factors that cannot be changed can be used to identify groups of people at increased risk and to develop targeted interventions. Upstream or distal health factors are macro-level factors such as global forces and government policies. Upstream public health approaches try to prevent health problems at the source, so they don't need to be fixed downstream. Factors such as community design, education, employment, living and working conditions, and poverty are major determinants of health that may be addressed upstream. We can also look at underlying causes of disease or health outcomes in populations. For example, underlying environmental, economic, social, and cultural factors. Such underlying factors, for example, may affect how viruses mutate over time and adapt to their environment. When we talk about the population perspective, we are referring to a web of causation where many factors may play a role in disease development. Factors include family support, social networks, global climate, labor conditions, tobacco production, or even advertising. Each and every one of these may play a part and should all be considered when deciding public health interventions. A population health perspective can also focus on health disparities, especially health disparities related to social economic status. All epidemiologic research involves some sort of population. Every population has its own history, culture, and economic and social context, which influences how and why people are exposed to risk factors and how people are affected by their exposures. Population research begins by considering the distribution and determinants of health outcomes at a population level. Though population research may also include individual and micro level analysis, an understanding of the historical and social context of health outcomes is important in order to conduct effective research and to design effective interventions. We can illustrate this with lung cancer, a disease that is well understood. Most cases of lung cancer can be attributed to cigarette smoking. The biomedical mechanism of lung cancer through cigarette smoking is understood. It is well known that carcinogens in tobacco cause disease, and the addictive properties of nicotine make it difficult to quit smoking. However, there is a social context to the disease, since culture and social factors can influence who smokes and who doesn't smoke.